Our objectives for today: recognize the difference between known fallers and at-risk for falls patients. What an important differentiation. Describe fall risk reduction through individualized fall prevention management to promote patients' function, independence, and safety. Elevate the prominence of emergency departments within the care continuum as a critical point of care for fall prevention. Those are the objectives, but this is what we want for you as your takeaways. Organizations must stop over-reliance on fall risk scores. As nurses, we've all learned fall risk scoring, but you're going to hear a counter to that. Emergency departments are the critical point of entry for known fallers, and fall and injury prevention for known fallers must be individualized based on fall etiology.
I'm so committed to helping us all appreciate the burden of falls because it is great. You know what? Every minute counts. CDC's analysis of 2019 unintentional injury deaths helps us to know that falls were the leading cause of unintentional injury death in the entire US population. This is across all age groups. Falls was also the leading reason for unintentional injury death for older adults. 56.5% of all causes of unintentional injury death. And this is older adults. Every year, 3.7 million Americans turn 65, and I'm proud to say I'm in that age group. And according to Factura and others in 2021, adult ages 65 and older, we're twice as likely to fall than younger adults. So every year, more than 1 in 4 older adults will fall. And that includes me. More than half of those who fall don't tell their healthcare provider. And I have to tell you, Lole, this is so important to me because I know that adults won't tell their healthcare providers, but you know what? Oftentimes older adults who live alone won't even tell their families. Don't you know that that's true?
Absolutely.
Absolutely. So every 20 minutes in the United States, an older person dies from a fall. And we know this from CDC. But those who actually do come to the emergency department, those 37.5% that make it to the emergency department, and this is my special focus on emergency departments, these colleagues are what I refer to as the known faller. Patients who fall and actually get rescued by EMS and actually present to the emergency department. Out of those 3 million or 37.5% who actually come into the emergency department, there will be 31.7% or 950,000, this is estimated, that actually will be hospitalized. So every one of you who is on this call, you should know what percent and what numbers are occurring in your emergency departments of those who actually present into your ERs. But I want to give you the other side of the equation. And I always talk about the other side of the equation, just like falls. You have a fall rate and then you have the rate of those who don't fall. I want you to think about the percent of patients who actually get sent home who come into the emergency departments. So you have 68.3% of known fallers who had an injury that presented to the emergency department who actually get sent home, to their home, to a family member's home, to assisted living, to long-term care, post-acute care, or rehabilitation. So that's a huge percent, and that's why I spend a lot of time also focusing on that population. But then sadly, out of all these numbers, we have 32,000 patients, older adults, and dies from a fall, 3.4%. And this to me is just so very sad. And I'm so delighted that we're together to be able to address this because we all own this and we all must do something different. And that's why we want you to recognize the difference between known fallers and those who are at risk for falling patients. With known fallers, absolutely, we need to be able to triage them based on presentation and etiology of the fall. Because how you treat someone who presents to the ER because of a fall when they fell out of a car losing their balance versus someone who is orthostatic versus someone who had a stroke is going to be very different. So that's why in emergency departments, we want to be able to triage. And if someone is injured, of course, the first thing that we're all going to do is to treat that injury first. Stabilize medical conditions, and then determine the trajectory of care, which we will be talking about. And then there's all the other patients who are presented to emergency departments who are at risk for falls. Who isn't, unless they're in coma? But they're all at risk for falls. So that's everybody else. And then we have those who are older adults who are admitted to the emergency department that were not admitted to the ED due to the fall. So we should all be addressing them and then screen for fall risk and then determine their trajectory of care as well. Align these two types of falls that are preventable. And now we're moving into some precision. We have moved away from universal fall precautions. So the very first recommendation is we all have a responsibility when patients come into our care, into emergency departments, any point of entry, to implement a safer care environment for the entire patient cohort. And you can see what that is: flooring, lighting, those kinds of things. And that's predominantly what universal fall precautions is anyway, is environmental safety. But when you're creating a safer environment, you are reducing accidental falls. You should always be clear when you're implementing interventions, which type of fall are you going after? So this is accidental falls. The next two recommendations from this article, which are really important, and I really want you to emphasize this and have this as a point of discussion when you go back to your falls committees, is to identify specific modifiable risk factors. All of us live with risk factors for falls, but some are modifiable and some are not. The ones that are modifiable, what we're supposed to do is we're supposed to treat it. So if someone has postural hypotension, we should work it up and treat it. If someone's got centrally acting medications that can be modified, we're supposed to modify those medications. When we identify risk factors and we develop a plan of care to implement, to mitigate or eliminate that fall risk factor, and I hope you can see me, is we're now addressing anticipated physiological falls. So the two types of falls that are preventable in our emergency departments, in our healthcare systems, all across healthcare, in homes, are accidental falls and anticipated physiological falls for the most part. And then the last recommendation in the Oliver's article, which I hope you will really hear these words, is to implement interventions to reduce the risk of injury for those people who do fall, because you have patients who are going to fall in your care. You just want to make sure that they don't have an injury. That, remember, we're talking too about those patients who are present because of a fall. You just put them at high fall risk and be done with it. But some of the screening tools that are out there, the Australia one, the fall risk for older people in the community, they actually ask about falls in the last year. Well, that's not what we're looking for in the emergency department. That's what we do in the primary care, is you ask about how many falls you've had in the last year. When people are coming to the ER, you need to know why they came to the ER because of a fall. But if they've had a recent fall that is maybe a biological marker that something is going wrong, that it contributes to those anticipated physiological falls. So I have three populations I really want you to address in your emergency departments, in your healthcare system. And on this slide, these are patients who actually get admitted to your emergency department and they get sent home. And what percent of those? Over 60%, over 67% of your patients who present to your ERs who actually get sent home. And in all the emergency departments that I've worked with, I have always asked the ERs, if you have a patient that you actually send home and they came into your ER because of a fall, if you have the opportunity to do a satisfaction survey questionnaire with them, is ask them if they fell again after they left you. Because this is a real problem. Patients who come into the ER and they get sent home and they fall again and they get sent back to us. We know this happens with EMS and doing these lifted assists, fall assists up from the floor, that patients will fall again within 2 weeks. But I want you to also think, colleagues, and Lele and I have done so much work in this area, about those patients who are truly vulnerable. It doesn't matter what their score is on a screening scale. It does not matter. For people over the age of 85, we know from CDC, their data, that their leading cause of unintentional injury death is a fall. You have got to protect them differently than anybody else, just like infants and toddlers. People who are frail, you know if they fall, they're going to break. They don't even have to have a head strike to have a delayed onset subdural. People who are known fallers, which we've spent time talking about, and I hope that this will be your new patient cohort as you go forward with your fall and fall injury prevention program. Anyone with a hip fracture that comes into your care, my goodness, you cannot let them fall again in your care and have another hip fracture. You cannot do that. You have to protect them in a different way. Floor mats. I even have one hospital right now that actually is beyond the VA that's using hip protectors for people who have already fractured a hip. Certainly for people who are dementia, remember that there's a wide range of severity for cognitive impairment, mild cognitive impairment versus severe. But those are patients where you've got to anticipate their needs, and talk to their family members. I took care of my mother that had Alzheimer's disease, and I could tell anybody how to anticipate her needs based on what I knew. But perinatal patients, and there's others that are out there, hospice that are fiercely independent, are going to do everything they can to stay as independent as possible.
Thank you for watching this webinar preview. My name is Julie Cullen, the Managing Editor of American Nurse Journal. I invite you to watch the full version of this free on-demand webinar. Just follow the link in the description. You can also visit myamericannurse.com for a full collection of our free webinars. Thank you.